Thank you, Alexander. And I'm a cardiothoracic surgeon, and I'm going to talk to you about this, should someone say, controversial topic. But this is Iceland, taken several days ago. It started to snow, not in Reykjavik still. So it's different for me to come here for 25 degrees. There is never 25 degrees in Iceland, not even in July. But we have bonuses as well. It's not just in Barcelona where you have nice evenings. And this is taken 3 days ago in Reykjavik. The Boreal Aurealis, the Northern Lights, which were unusually nice that evening, cold evening. And this is even more nice to take the tent out where there is no light pollution, and it's a little bit colder than here, but it's still interesting. But as you know, for acute coronary syndrome, the primary treatment is PCI. And this regards unstable angina, NSTEMI, and STEMI patients. And the question is there any role for cabbages or myocardial revascularization in this group of patients? And the short answer is yes, and I'm going to show you data to support that. And in what patients is cabbage indicated? It is first of all when PCI is unsuccessful or not suitable. There are complications of PCI, for instance, dissection of the coronary artery or even pericardial tamponade or some other complications. And then, of course, if the patient has advanced 3-vessel disease or even left main disease where PCI is more complex to perform. But before I present the data to you, I want to make sure that we are using the same definitions. And this is actually specified in the Euroscore 2 criteria. An emergency cabbage is an operation performed before the beginning of next working day or after the decision to operate was made. And this is important that when we are comparing studies that we are using the same definitions. Salvage cabbage, which is actually a more controversial procedure, is an operation requiring cardiopulmonary resuscitation en route to the OR or prior to the induction of anesthesia. If we look at the literature, there is actually studies missing on this topic. Of course, because these are rare procedures, and those studies published often include quite a few patients from single centers. And in those studies performed that are often of relatively poor methodological quality, the mortality is between 2% and 30% versus 1% to 3% for elective cabbages. And the complication is very high. These are perhaps the 2 major publications in JACC 2005 and ATS 95, but there are not many recent publications on the issue. And these patients, they bleed more, we know that. Of course, they have more meds on board when the operation is performed. And in some instances, patients can end up in the ICU with a situation like this, a stone heart requiring ECMO with open chest. But nota bene, this is not a regular thing happening after these procedures. So are these procedures justified? As I said earlier, the answer is yes. I'm going to present to you a paper that was published in November last year on this issue. It's the Nordic Emergency Salvage Coronary Artery Bypass Graft Study. We call it NES study. And it is my resident, Tomas Gudbjartsson, who is the first author and has done most of the work, and I have been the co-author. No, the senior author, excuse me. And our objectives were to study in a contemporary multi-center patient cohort the incidence and indication of these procedures, complications, survival, and tried to define prognostic factors of both 30-day mortality and long-term mortality, and also see if these procedures are futile for subgroups of patients. And this actually includes 4 Nordic university hospitals in Finland, Sweden, and Iceland. And there are actually 22 centers in the Nordic region, and Iceland is the smallest one. And this was Gothenburg, Tampere, Turku, and Reykjavik. And my student, Tomas Andri, moved between the centers to collect the data. And just to show you how different in numbers these 2 subgroups are, emergency CABGs performed before the next working day are much more common, on 94% versus 6% of the salvage patients. And this was expected, but this is important for you to know. And if we look at the patient demographics, and we are dividing them into emergency and salvage patients, you see that the age is similar, around 66 years. Males are more common, but, however, like in Iceland, for elective coronaries, women are around 20 to 25% of the patients. So there is relatively more females in these cohorts, both for the emergency and salvage patients. Around 30% of the patients had diabetes. Extracardiac arteriopathy was around 17%. And here you see the logistic Euroscore, 16% for the emergency patient and 36% for the salvage patients. The Euroscore 2 for the same subgroups were 4.3% and 70.7%. And what were the indications for these procedures? Most of these patients actually in both groups had STEMI. But as you can see in the salvage group, it was 71% compared to 36% in the emergency group. And the others then NSTEMI and unstable angina pectoris. And it's interesting to see that almost half of the patients, 52%, had left main stenosis, as shown here. 3-vessel coronary disease was found in more than 2/3 of the patients. And in 1/3 of these patients, PCI had been attempted in the PCI lab. And in 7% of these patients, severe complications had occurred. So they were transported directly to the operation room. And just to show you also that many of these patients had low ventricular ejection fraction, less than 30%, and up to 50% of the salvage patients. They had required preoperatively high doses of inotropes, and 1/4 of the salvage patients and 13% of the emergency patients had received intra-aortic balloon pump preoperatively. Now we come to the intraoperative data that is perhaps interesting for you as a perfusionist. But the LIMA was used in 82% of the patients in the emergency group and almost half in the salvage group. And this came as a surprise. In some centers, it is a rule, at least for the salvage patient, not to use LIMA. As it should be a fast procedure and especially going fast on machine. But the CPB time was 77 minutes and 111 minutes respectively. And what was also nice to see was that full revascularization was achieved in most cases, almost 80% even in the salvage group. And here you see that at stenotomy, at the start of the operation, 26% of the salvage patients required CPR, 1/4. And here you see the LIMA takedown. The message is usually under our training as surgeons to go as fast on bypass as possible to rest the heart. And then there are different opinions on if the LIMA should be taken down after heparinization or not. And as you can see in this study, in these centers, in most cases that had been done. But some centers prefer to use vein grafts only in these cases to reduce the risk of bleeding. And otherwise, as I showed you here, the Lima is here on site, and the average number of grafts was 3, which is quite comparable to elective CABG, which is 3.2, and the similar techniques were used. Actually, there were 23 patients, or 4%, that were done off pump, which came to a surprise to me that this was done, and 5 of these patients were done on bypass but with a beating heart. And most of these, all these patients were in the emergency group. Postoperative complications were more frequent than after elective CABG. ECMO was required postoperatively in 2% of the patients, and you see that re-op for bleed is 15%, which is 3 to 4 times more common than an elective procedure. Stroke was seen in 6%, which is 3 times the regular rate, and dialysis first time required in 8% of patients, either in the ICU or continuing after the ICU stay. And deep sternal wound infections in 4%, which is the double as the 2% that is after cabbages in the same centers. Now we come to the major findings of our study, the primary, so to say, goals of our study, to study in-hospital mortality. And you see here that in the emergency group, the mortality, in-hospital mortality is 13%. We decided to take in-hospital mortality and not just 30 days mortality, as many patients live longer than 30 days in the ICU. And in salvage patients, it's 41%. In total for this group, that is, of course, quite different, as I pointed out, the total mortality in hospital is 15%. And we did some prognostic factors to see what patients had higher mortality in hospital. And you can see here, as no surprise, advanced age made the prognosis worse if the patients had either carotid or femoral or leg ischemia, low ventricular ejection fraction in the left ventricle, and if they had required high doses of inotropes or intra-aortic balloon pump. But this is an interesting findings. One of our major findings was the cumulative survival. It's overall survival in the 2 groups. And here you see the red line is the emergency group. And you can see that 5 years after surgery and still 12 months after surgery, the survival is over 80%. It's 85% at 1 year and 79% at 5 years. For the salvage group, as you can see here, the mortality is much higher during the first 30 days, 60 days, but then stabilizes and is actually quite good from year 1 to year 5. So this means that if these patients survive surgery, the long-term prognosis is quite good. And this came somewhat as a surprise, especially for the salvage group. And here the prognostic factors for long-term survival, and I would stress that this only includes the emergency patients because the salvage patients were so few, so we did not include them. But it's the same here for long-term survival. It's very similar to the in-hospital mortality: age, diabetes, extracardiac arteriopathy, low left ventricular ejection fraction, inotropes, and intra-aortic balloon pump. I mentioned to you earlier that's also important in a study like this to try to find those patients that do not benefit from the study. So we looked especially into the salvage patients. They were 34, even though they came from 4 centers. And you can see here that the Euroscore 2 is 17.7%, but the logistic Euroscore is 36.1%. And then if you jump down here to the in-hospital mortality, you see it was 41%. So this means that the logistic Euroscore is more representing these, the true mortality of these patients than the Euroscore 2. at least in this subgroup of patients. And 2/3 of these patients were transported directly from the angio lab to the operating room. 50% of them had PCI complications, and 6 out of them required ECMO postoperatively. And after 1 year, the survival was 50%. And as I showed you earlier, it's stabilized out, so there was not so much difference between 1 and 5 year survival. And this is overall survival. We are taking into account all causes of death. But what is interesting is that 8 out of 9 patients that needed CPR at sternotomy, when you are doing CPR and starting the operation, and you guys are ready to go on pump soon, they almost all died except one that survived for 22 months. So this is a subgroup where you should really consider if proceeding or not. So my conclusion, or our conclusion, are that early mortality after emergency and salvage CABG is substantial, especially in salvage patients. And life-saving emergency and salvage CABG is justified in most patients, but salvage patients have dismal prognosis if CPR is needed during sternotomy. So this is the main message. But these operations are justified, but you have to find out the right groups to operate on. Finally, I want to show you a picture taken 10 days ago, 2 hours from Reykjavik, where I live. And here is my group of, not patients, but my colleagues. And this looks like Lord of the Rings. But this is a true picture. It's not stolen from the internet. Thank you very much.